you very much for your precious help in my previous hospital. Help us.
Firstly, thanks very much. The privilege is all mine to be back home in Athens. My wife thinks I spend more time here than anywhere else. But it is, but it is a real pleasure, and it's great to see lots of people where I've had the privilege of working with you in your respective centres. So I wanted to try and give you something a little bit more potentially interesting. We say antegrade versus retrograde. But what I want to do is talk a little bit about how we negotiate our way through CTO cases and how we can bridge a training gap. Because, of course, what we know and what I've been training on, what you'll be familiar with, is the hybrid algorithm. And it's not antegrade versus retrograde. It's at any time we can set up to be able to use whichever one we need. And we know from this algorithm, you don't need to remember it, just some key facts. Number one, anatomy dictates our interventional strategy. Number two, we should fail fast and switch quick to a different strategy when we need to. And then therefore, number three, by definition, you need to therefore be trained in all of the techniques in order to have something to switch to. And this is what I've been training on for a while. So if I take your title at face value, things that drive us to go retrograde are cap ambiguity at the proximal cap, a poor distal target. If you've got great interventional collaterals that you can put your arms straight down, you're going to favor a retrograde approach. And if there's major side branch at the distal cap, we're going to go retrograde. Those are the things that drive us to go retrograde. So here's a classic retrograde case. And by the way, let's just point out that in the debate over CTO, not CTO, these patients don't get in. This is a post-CABG patient. They've got a chronically occluded right coronary artery. It's really long. It's an ambiguous cap. There's a bifurcation at the distal landing zone. So, sorry about this. Hang on. So here you can see there are interventional collaterals, bifurcation at the distal landing zone, and you can see here there's complete cap ambiguity. You don't know really where to start. So this would be a retrograde case. That's fine. You know, the algorithm tells you that anatomy dictates strategy. The question is how? How do we do it? And at the moment, it can be really, really difficult. One of the things that we've done is we dispelled dogma by showing that we can use dissection techniques, but we've created some dogma of our own, and that is over the last 10 years, 15 years, I've been telling people, well, you can't teach wire skills. You've got to learn to knuckle and dissect. And I want to dispel that. I don't think that is true. What we've seen is a huge evolution in wire technologies. So we now have many more wires. We've got them backed with microcatheters. We have dedicated re-entry devices. Now, the issue is, how do you integrate all of those? Because we've got our algorithm, but the algorithms themselves have evolved, and now we have algorithms within algorithms for the proximal cap or getting retrograde. So we're having to hold on to a lot of information. And what I want to do is propose to you a different way of thinking that sits alongside our algorithm. Anatomy dictates strategy, but it doesn't tell you how we're going to do it. I would like to present a way of transferring and teaching wire skills that should aim to bring more people into CTO and demystify it, but also for those of us that are experts in the room, it should force us to make decisions earlier and switch strategy and be more efficient. And this is the concept. We call it differential resistance wiring, and basically, it puts the wire, the coronary wire, back at the center of the journey. The wire is the star of the show, because if you're doing a CTO case or any case, you've got to pass the lesion with a wire, otherwise there's no therapy. So central to differential resistance wiring is that at any given point in a case, at any time, you've got two decisions to make. One, what is the specific task for the wire? And two, most critically, am I seeking to move towards resistance or against resistance? That's basically it, and that's why we call it differential resistance wiring. So the idea here is that you decide the task for the wire. So you'll need to know some feedback to know whether that was successful, and that will be tactile and it will be visual. And then if you know the tactile and visual feedback that you want for the wire task that you want to do, well then the wire should select itself. So the fact that there are 50 or so wires on the market, you need to choose the one that's going to do that job. Now, wire tasks, well there's a lot of things that you can do with a wire, but I would flatter myself to believe that you can deconstruct it into just 4 constructs: grip, stick, steer, and drive. Grip means I'm moving over a short distance and then aiming to continually meet resistance. Stick, well, we all know what that is. We're penetrating, but we're penetrating from high resistance to low resistance over a short distance. Grip and stick, we always do against resistance. Steer and drive is how we purposefully move through the CTO body. Steering is active. I'm deciding I want to go left, I want to go right, I'm going to turn this way or that. Drive is different, but we do a lot of this in PCI. What we're doing is we're allowing the properties of the wire to interact with the properties of the vessel as we push forward. And it's the vessel and the wire that dictate the direction, not us. And that's called a drive, and it becomes relevant. Okay, so how do we know what we want to feel? Well, we say that we feel a lot of things. We feel the wire is true or free or in or out or subintimal, and I'm going to tell you none of that is true. None of it. What you feel is resistance or no resistance. If you're in, you know resistance. If you're out, it's no resistance. If you're subintimal, bit more resistance, but can you tell me by feel alone whether that's against plaque or whether it's subintimal? Yes, you'll have more resistance against calcium, but that's when you're against calcium from within or without the vessel plaque. So the next thing you have to realize is that with CTO, you feel with your eyes. And it's your eyes that give you the visual feedback that you want. So when you advance a wire, you can push it forward and it may not deflect, it may deflect, you may want it to fold and knuckle, and it can longitudinally compress. Here you'll be familiar that if you stick the green wire from high resistance to low resistance, but it's out of phase with the distal vessel, it's going to be out of the vessel architecture. If you drive the knuckled wire continually against resistance, it's likely to remain within the vessel architecture. You feel with your eyes. So here's a wire that I'm pushing forward and it's in the distal true lumen. I can see it's in the distal true lumen, but it's incredibly resistant when I push it through. I'm pushing and my guide's trying to push out. Well, that's exactly the same as the resistance that I would feel if I'm pushing on this wire and it's wrapping around the vessel. Why is that? Because here the source of resistance is in the CTO body, and here the source of resistance is at the distal cap. We need to understand visual wire behavior in order to understand the resistance that we feel. Now, once we've got all of that, then if we know what we want to do, we know what we should feel, resistance or not, we know how the wire should behave or what wire behavior we want, knuckle, straight, bend, then we can select the wire appropriately. 50 wires on the market, how are we going to choose? We only need to know 3 things. Is it polymeric and super slippy and lubricious? Is it tapered? And what's the tip load? High, medium, or low? Let's put all of this together and see how it works. Here's a case. Let's do it by algorithm. It's long. It's got a clear cap. It's got a good distal landing zone, but it's an LAD, and LADs have lots of side branches. So by algorithm, it's an antegrade dissection reentry, but most of the time we probably want to wire it because it may be subintimal for some, there may be some intramyocardial segment or we'll lose branches. So we've got to get through the cap. That's the most straightforward conceptually. We're going to stick. It was really resistant. I needed a dual lumen microcatheter, so I take a wire that's going to stick against high resistance, and I want to see the wire penetrate, and here it doesn't bend, so I need a non-polymeric tapered high-gram wire. What happens next? Well, we come into the CTO body with our microcatheter, and what we're now going to do is drive. I want to drive down towards the distal cap. Why it's a drive? Because what I'm going to do is take a wire that is now going to I don't know what I'm going to get. I'm going to allow the wire to interact with the vessel, and what I see is actually I expected it might knuckle, but it's run straight. It's felt some milder resistance. I see it run straight, but it's definitely not luminal. It's adjacent to the lumen. So I take a polymeric no taper medium wire to deliver this drive down towards the distal cap. Here's the key, though, about differential resistance wiring versus ADR. I don't need to cross the distal cap. My wire task has changed. What I want to do now is grip some tissue. I want to meet resistance, and I want to steer continually away from resistance. And what I want to see is separation from my other wire in the direction that's designed by the vessel, so that we take a non-polymeric, tapered, medium weight wire, this is a Gaia second, or you could take a Gaia third, is going to make its way through this lesion until we meet some resistance at the distal cap, and then the wire meets no resistance. So I'm either out or I'm in. How do I know? I feel with my eyes. We do a retrograde injection and we're in. And then we open the artery. Is that parallel wiring, or is that antegrade dissection and re-entry? Let's have a little look. Well, here we are. We're in the plaque at the beginning. We went subintimal, so technically speaking, we've re-entered. And then we go past the calcific lesion. We get an extra side branch on the way down. And then we're in the distal lumen. What you realize by putting together this construct is that parallel and ADR are not opposites. They're actually a spectrum. So that when you do go beyond the distal cap, and that's all that antegrade dissection is, it's going beyond the distal cap and re-entering, you realize it's a wire skill set, not necessarily a device skill set. And in order to do it, you have to learn wire behavior. So you have to push a knuckled wire. A knuckle to dissect is pushing a polymeric wire against resistance and seeing a particular behavior. And then when you bring your stingray in beyond the distal cap, you need to stick and drive. You need to then use wire skills to cross back into the true lumen at the right time, gaining all the outflow branches. So this is where we started, just to end up, which was our retrograde case. So can differential resistance help us here? Well, yeah, when we come through a retrograde collateral, now we want to move away from resistance with a super soft wire. Now we're steering against no resistance. We're seeking no resistance. When we meet resistance, we steer away from it. And then when we get to the distal cap, you can see that this wire is stuck. It's all knuckled, but it won't penetrate. So I need something to penetrate. So I need to stick, and then we need to steer against resistance until I can get my knuckle going again. I can see I'm running out of time, but broadly speaking, what we then want to do is just simply, I'm not going to go into the different types of knuckles other than to say that you can describe knuckle behavior in terms of resistance, no resistance, and visual wire behavior. And the key then is to connect up the spaces. When we connect up the spaces, what we want to do is puncture the cap. So the task for the wire is stick. Then once we puncture onto the cap, we overlap our knuckles, so we drive knuckles in both directions. And then once we've ballooned, we need to steer our wire into the antegrade microcatheter. So these are all ways of negotiating our way through the case by recognizing what the wire behavior should be so that we can fix the vessel. So my message today for you is antegrade or retrograde, anatomy dictates strategy, but how we're going to do it is by thinking differently about our wire skills. Grip, stick, steer or drive, resistance or none, understand our wire behavior and select the wire appropriately. And that way, hopefully, we can start to untangle some of the algorithmic challenges that we have, because it doesn't matter whether you're going parallel, dissecting or re-entering. From my point of view, it's all wire skills. And to separate out manipulation of a wire over a short distance versus knuckling over a long distance, as one is not wiring and one is unhelpful. It's all wiring. And I think these task-based skills are teachable. I don't think parallel and ADR are opposites. And I think that if people start to adopt this way of thinking, then potentially we can get more people into this space and meet the need, and also enable us to make decisions better as expert operators. So that's my call to action. I'm going to stop there. None of this has yet been published, but it's a work that we've been putting together over the last year or so, and hopefully we'll publish a paper soon, and people can start to learn whether these training concepts and wire concepts actually achieve what I'm setting out to do. Thanks very much.
Thank you very much for the excellent, very comprehensive and informative. Do you have any comment from our discussions? We have some CTO operators here. Dr. Dardas, Dr. Dimopoulos.
If there is no question, just...
There is one. There is one.
Okay.
Congratulations, it was really superb talk. If we say that you don't have unlimited access to unlimited wires, what would be your preferential wires that you choose?
Yeah, it's a great question, and it talks very much to this. So what tasks do we need to do, really, is the answer. So we need to have, if you're going to do CTO, really you need to have groups of wires. The first are low tip load, tapered polymeric wires for loose tissue tracking against modest resistance that are going to slip easily but give you a bit of penetration. So you need something like the XT family, Fielder XTA, XTR, you only probably need one of them. You need some medium polymeric wires. They're going to do a lot of the legwork because they'll knuckle and they'll steer you through long segments of disease, and they won't usually exit. But ultimately, as I've just shown you, whether you're sticking the proximal cap or re-entering or going through calcific tissue, you're going to need some super stiff wires. So you need one of a Confianza Pro 12, a Hornet 14, and if you just had, probably for me, a Gladius, Gladius EX, Gladius MG, we could talk about the differences. You had a Fielder XT, you got then that will do a lot. And then finally, and very importantly, for the differential resistance, for moving within CTO bodies and seeking resistance and or plaque, that you need the Gaia wires for. And I think you only need a Gaia second and a Gaia third, or a Gaia next second or a Gaia next third. So you can get it down to about 4 or 5 wires Antegrade. To go retrograde, you have to have a Scion, a Suo 03 and a Scion Black. And that pretty much, then finally, externalization, one externalization wire. And that's all you need. So what's that, 7 or 8 wires? It's not 50. Choose your favorite ones, work with them a lot, but those are the flavors that you need.
Do you have any experience with the new Miracle, the Neo 3?
I do, and again, with this framework, I mean, everything for me is now draw, but with this framework, you can describe instantly exactly where it fits. So what we've got is a medium weight wire. It's got a hydrophobic tip. And it's designed very much like Gaia, except that it's not tapered. In fact, more than not tapered, it's completely flat and blunt at the distal tip.
It doesn't exit.
So what that tells you instantly is it's going to be terrible at penetrating proximal caps. Don't use it for that. If it goes through the proximal cap, it's probably because the proximal cap wasn't so troublesome anyway. It will negotiate through CTO bodies against resistance, either intraplaque or extraplaque, but it probably won't help you get from one to the other. And it's probably safer, it's probably a safe wire that's not going to exit, but I would put it to you that for me, in my work, I'm not sure where it's going to fit. I think that you can do those jobs with lots of other things. And it was engineered for a market where we're saying we're getting younger operators and we don't want them perforating vessels with stiff Gaia wires. Can we get them using something that feels a bit like a Gaia that's not going to cause harm? So maybe it's a sort of going to be a junior trainer wire. The other place that I think it could be really helpful, but I'd like a stiffer version of it, would be going through old stent occlusions. Right. Ones where you don't want to keep snaking outside and inside stent struts, you want to stay within the body, but you know where you're going. There's no ambiguity, you just need enough push to get through it. And sometimes if you use a polymeric wire in that setting, it sort of gets pushed off to the side, picks up a stent strut, goes back in again, and then you've got a nightmare trying to get through that. So again, you can, any wire you design, you want to design, you can determine from its characteristics what its task should be.
Okay, Dr. Dianis.
Yeah, I think that the most difficult part, even in a retrograde or a retrograde CTO, is the re-entry. How often do you use dual lumen catheters or special devices in order, let's say, to get in the true lumen?
Yeah, so when I'm working antegradely, I use dual lumens a lot. I tend to like the recross, not because it's so unbelievable at crossing lesions, but it just gives you lots of opportunities for 2 over-the-wire ports to renegotiate and redirect. But you've got to know where you're going. So I will be very comfortable to use a knuckle type technique because I'm come from a dissection strategy and then redirect against resistance within the CTO body. But sometimes if I'm not catching that resistance, fine. Cross the distal cap and I'll re-enter with Stingray. Stingray is very, very focal. It's very accurate. The exit ports are where the exit ports are, so you can see where you're going. Re-entry retrogradely is about connecting spaces, and that's about understanding reverse cart. That's a separate lecture that I nearly gave today, but I decided I'd show you some of these concepts. And that is the biggest thing to get your head around, that doing a retrograde case, you think it's about getting retrograde, and then all of our journey as CTO operators is first time you get retrograde, and you've got the microcatheter through, and you've been through the collateral, I'm retrograde. Right, what now? You know, it's like, it's really hard to get your head around how you connect spaces. So that's what you need to go to online forums, look at lectures, come to meetings, and understand how you connect up spaces within the CTO body. That's an extra lecture.
Thank you.
Okay, thank you very much.
A question, just a final question. Do you have data, a clinical question, do you have data that show an increase of arrhythmiogenesis or DC shocks in this kind of patients?
In terms of patients where you've recanalized their CTO? Yeah, we do have, we have data on healing. So we did a really interesting study towards the end of the last decade called Consistent CTO. Because what we wanted to do is try and dispel this myth that if you get an artery open, you go subintimal, that the healing will be worse or that's worse for the patient. What we learned from that is that as long as you get great outflow into all branches, we can't have these long dissections going off into one tiny branch. If you get outflow into all branches, healing is similar, whether you're subintimal, whether you're at a re-entry zone, or whether you are intraplaque. And the thing that's going to separate it out is how well you do it. So getting maximal expansion, making sure that you avoid super long segments, you keep it as short as you can. And we're doing a lot more hybrid type procedures. But we've shown healing is good. But at the end of the day, if you've got a CTO and we're going to be opening a CTO post-bypass surgery, this is not natural healing. None of this is natural. Let's get over that as well.
Okay, thank you very much. We have to proceed.